Good afternoon and thank you. We have an esteemed panel, so I thought I'd spice up your afternoon with a disaster case that gave me emotional turmoil for a bit. Rather than go through some slides, I'm going to kind of go through a slide and open it up so that the panel and the audience can pick it apart. These are my disclosures. We have an 85-year-old male, history of hypertension, hyperlipidemia, COPD, and then history of ascending aortic aneurysm status post bioprosthetic AVR and ascending aortic replacement in 2002, who developed some fatigue, had worsening dyspnea on exertion. The TTE and TEE showed severe aortic stenosis of the bioprosthetic AV, so the patient was going to go with structural for TAVR. The pre-TAVR CTA showed kind of a steep aortic arch, but overall looked okay. Diameter looked okay. Access vessels looked okay, so the patient went for a TAVR. No aneurysm, no evidence of dissection. The TAVR reportedly went very fine. Bilateral percutaneous femoral artery access on the right with the 14 French, on the left with the 6 French, and left femoral vein access, and they put in a Medtronic Evolute Pro. Per report, no difficulties in actually getting the device up over the aortic arch. Final distal angiogram showed patent iliac arteries without dissection, and perclose was used in standard fashion. Post-op day 1, patient starting to complain about severe lower back pain, was ordered for a stat CT angio. And here's the CT angio coming down. Oh, yes, that's the reaction I was hoping to get from you guys. So you can see a pretty bad dissection that starts from the aortic arch that comes all the way down. If we let this kind of cycle through one more time, if I can do that successfully without not messing this up, one of the other features to note is that the true lumen gets completely collapsed. This smaller one in the posterior side is the true lumen, and it's completely collapsed going all the way down to the iliac vessels. With celiac, SMA, and right renal are supplied by the false lumen. Yeah, we'll talk about that in a second. And I'm curious to later, when we talk with the panel, whether or not this is a portion that you would have gone straight to the operating room or not, and I'm open to take some suggestions for that. We opted to put this patient in the ICU with aggressive anti-impulse control, and the patient's pain started getting a little bit better, and it looked like they were doing okay. You just heard a talk where you don't want to rush to the operating room a lot of the times in these cases because you're worried about a very unstable aorta where you can things make substantially worse. Post-op day 3, we made it to post-op day 3. He had really bad chest pain, became hypertensive to systolics of 160s and became lethargic, and that's the chest x-ray from that morning. Horrible. Clearly, something doesn't look right. The H&H was stable, but we obtained the CT angio, and within the course of 2 days, that aorta had evolved into something that looked like this. So once again, you see a hematoma up that ascending arch. You see intramural hematoma going all the way down. That true lumen, once again, was significantly compressed coming all the way down. Now, despite the true lumen being compressed, there were no signs of malperfusion, even on that post-op day 1. The creatinine was relatively okay. The patient was not having abdominal pain, and the lactate was okay. And as you can see, this is a horrible, ugly-looking CTA. Here's it from another view. You can see the TAVR in place, and essentially the hematoma is going to come all the way down through this length of that aorta. Well, this one cycled through as well, extending all the way down into the iliac system. So at this point, I think everyone would agree, you cannot wait on this. This one goes to the operating room. When we went to the operating room, these were going to be our goals. Number 1, we saw intramural hematoma going all the way up, essentially to the subclavian artery, arguably beyond it, but in this acute setting, the goal was going to be to cover the aorta as much as possible to as healthy as possible, so we were going to cover up to zone 2 and cover the left subclavian artery acutely. Even before we even talk about all that, this was going to be a challenge. The true lumen was completely collapsed, going all the way down into that system, so we're worried about it. The goal here versus regular kind of type B dissection is different. This is a ruptured aneurysm, so we need to achieve some cessation of flow into the false lumen, even if it's there. So we have to try to minimize that flow. We have to plug that subclavian artery, and while we're doing all of this, remember 3 of the renovisceral vessels came off the false lumen, so we've got to make sure renovisceral perfusion is maintained. So we went in trying to do this, and access was challenging, but with a lot of help. This is the true lumen, and this is what the angiogram in the true lumen looks like because the true lumen is so decompressed from a highly pressurized false lumen, and consistent with what we had seen, only the left kidney comes off the true lumen. Everything else was coming off the false lumen. Terrifying kind of angio, but we were able to do it. We were able to manipulate our way all the way up to the ascending arch, and we put up a Lunderquist wire. We confirmed the true lumen location all the way through on IVUS. You can see a very mobile, relatively mobile, I guess this is a terrible IVUS clip to show a mobile septum. It was a very mobile septum that was very collapsed and was still moving pretty substantially well. And you can kind of see this hematoma going all the way up to the subclavian artery, which was consistent with what we had seen on the CAT scan. We performed a TVAR covering the left subclavian artery. This was the first. Most of the time, in these kind of cases, I cannulate the subclavian artery and embolize it first, but the goal was to try to cover as much of this as quickly as possible to make sure the patient doesn't get unstable. So we covered the TVAR all the way up to the left common carotid artery using a slightly oversized slightly oversized TVAR graft. Typically, for dissections, we're not oversizing more than 10%, but this was also a rupture, so I oversized a little bit more. In addition, the patient had an ascending repair in the past, so I was a little bit less concerned about a retrograde type A dissection, and I wanted to make sure I achieved the seal. Now, distally, we always talk about don't balloon in an acute dissection, but I felt in this kind of scenario, we had to achieve good true lumen expansion and try to create a slowdown of flow into the false lumen, because that's where the actual problem was. So we performed a Knickerbocker at some point in the mid of that TVAR so that we could try to expand that TVAR as much as possible. And then we came from a radial approach and plugged that using coils. And then the completion angiogram, thank goodness, showed all the vessels still being perfused with both vessels. So at this point, we decided we're not going to stent or do anything to the visceral vessels and hope that this was enough. And when you see the completion angiogram, you see contrast coming down, but even in delays, you did not see significant contrast coming backwards. So we thought, all right, maybe we're out of dodge. So here's the repeat CT angio. It was a rupture. It's our standard practice to get a repeat CT angio for ruptures. And unfortunately, it didn't look as good as we thought. Pretty good amount of contrast that's still coming up into that false lumen. You saw some expansion of that TVAR graft and that mid-thoracic aorta. But when we got this immediately post-op day 1 after the TVAR, we didn't think this was an acceptable result. And I'm curious to hear more panelists' thoughts about this, but we felt that in a ruptured aorta, this was way too much of a blush that we're seeing in the area. So we decided to take this patient back to try to limit the amount of flow that's going into the false lumen. And the goal was going to be to embolize the false lumen, Knickerbocker a bit more, and take the TVAR further down to try to get as much cessation of flow as possible. A couple good things when we went back to the operating room, the true lumen had significantly expanded. I'm so sorry, I don't know why my IVUS images look so terrible here, but the true lumen had significantly expanded compared to the first day, which we were happy with. We were able to cross over from the true lumen into the false lumen through one of the renovisceral fenestrations that you can see over here. You hear about a lot of different false lumen embolization techniques, including candy plug. We did not want to put something so big in the false lumen in a very acute setting, so we had opted to do an Amplatzer plug. There's 2 side-by-side Amplatzer plugs along with some coils in the back. We extended the TVAR further down, closer to the celiac artery, and then we Knickerbockered a little bit further more. All of this was an attempt to try to minimize the amount of flow. And I think our completion angiogram, you can see the blood going down to the true lumen, coming retrograde, and stopping pretty much at the plug and not going backwards. So during all of this, luckily, the patient was relatively stable. Here's a follow-up CTA that looks perfect. Unfortunately not. It doesn't look perfect, but I think it was a result that we were able to accept with significantly diminished flow in that false lumen compared to what we had before. And then circulation going to all of the renal visceral vessels. I'll let that cycle all the way through again so that you guys can nitpick it a little bit more. So if we have that come back through, resolving intramural hematoma, pretty decent wall apposition, coils along that false lumen, and then all the flow through that segment as well. So summary of some of the techniques that were used for this acute aortic complication. We had to do proximal TVAR extension to zone 2, left subclavian artery embolization, false lumen embolization, which I really haven't had to do in an acute setting such as this, but it was something that was necessary in this patient with the rupture, distal TVAR extension, and then other things to do cessation of blood flow into the false lumen. So I think this kind of case highlights a lot of kind of thoughts about endovascular management of acute dissection and rupture in these patients. So I'll open this case up for your review. Thank you very much.